in the nation. And I'd like to thank Dr. Hammer and his team for doing a lot of the work to create this. Dr. Hammer, you may not know personally, but he's been in the state for quite a while. He's from a large consulting firm that specializes in this work. He used to be the chief medical officer of Geisinger, one of the most respected health systems in the country. And Dr. Hammer worked with the state on its COVID modeling and also a wait time study to help us understand the challenges of getting into providers. So Dr. Hammer has a lot of experience in designing health systems for other states, other countries, and experience here in Vermont. He and his team have been here for about 11 months, meeting, he'll have data on it, but hundreds and hundreds of meetings with thousands of people to really understand the situation we have, so he can come up with recommendations that are really tailor fit for what we need here in Vermont. I also see Dr. Mark Levine here. I'd like to turn it over to Mark Levine to introduce himself.
Hey everybody. I'm going to keep this brief because Bruce's presentation is really the main attraction tonight. You must know who I am. So I work with the Department of Health. Consider me a representative of the Agency of Human Services tonight, which the Department of Health is part of. And the reason I want to stress that is much of what you just heard has to do with the prospect of healthcare reform. And healthcare reform, we are, unless something happened in the last couple of days, a state that is still part of the United States, and that means we need our federal payers, and we need to be aligned with a lot of the programs going on there. Most of you know that the all-payer model will be coming to an end, and there's a project called AHEAD that's been put on the radar screen that we could easily move into should we decide to, because the government is encouraging that. But the reality is, no matter what we design here in Vermont, it has to have a heavy influence by what we can negotiate with our federal payers and the structure of healthcare in the country. I say that only to stress that the team at AHS actually has a very long history and track record of working with CMS, working with the innovation arm called CMMI, to really hammer out the hard details which really help us move forward in the area of healthcare reform. I'm here to be a listener more than a speaker tonight, and really the goal, of course, is high-quality health care for every member of our community that's timely and affordable, etc. I just want to say one or two things that come from my expertise. We know the challenges. I don't have to repeat everything that Owen just said. There's demographic shifts, there's economic pressures, there's this COVID-19 thing that really has had a substantial impact on our population's overall health. And there's multiple other sequelae from it. We talk about multiple epidemics and we use the term syndemic. And right now, as you know, because you live in Vermont, we have a syndemic of housing insecurity, mental health and crisis, substance use disorder, and public safety, or at least the perception that public safety is a major issue. I could add even other things to the syndemic, but I think that's enough. And we have a healthcare system undergoing significant financial challenges. We have an interesting paradox in Vermont. No matter by what criteria you use, we will always appear in the top 5 healthiest states. So how can we be in the top 5 healthiest states? And you're going to hear some of the information tonight in the book that say, my God, we're in a financial crisis with hospitals, insurers, payers, you name it, all saying this is a real critical time, and yet we're very healthy. Now, as you know, we're not all very healthy, because if you look at the average Vermonter, or if you look through an equity lens at groups that have been disadvantaged historically and continue to be disadvantaged. But regardless, the bottom line is we are a very healthy state, but we do have a lot of compelling problems that really are placing a strain on our healthcare systems, hospitals, providers, insurers, and most importantly, what I'll term patients, every one of us. So we're very committed to looking for a kind of solution that will alleviate this financial burden issue while maintaining the high standard of care that has helped us earn the high health status that we have in this country. And I'm looking forward to hearing your perspectives. I could list a whole bunch of initiatives that we're all involved in right now that I'm not going to. Some of them will actually appear in some of the slides, and they're very important ones that we need to continue. And there are so many more that we're just embarking upon. And through further work with our federal partners in healthcare reform, and through the conversations that occur as a result of this presentation, and the recommendations that come from Oliver Wyman, but also that come right here from people who live in Vermont and have experienced the healthcare system and the crises that we're up against, we will come to some very important solutions. So that's all I will say, and I believe I'm passing the torch or the microphone on to Portland Medical Center now, which is, as you know, these are set up in regional ways, so they're all very much hinging upon the issues that your major healthcare provider in the area is facing. Far from me to be the one who's speaking.
Thank you, Dr. Levine and Owen, for the opening remarks here tonight. Good evening, everyone. I'm Bob Whitmire, president of Portland Medical Center, and also serve as president for one of our other partner hospitals, Middletown Community Hospital in New York. I want to welcome you all, including our guests from the Oliver Wyman team, to this conversation about healthcare here in Vermont, and especially here in Addison County. It's really great to see the turnout that we have here from the community. I know you all care about the services that we provide here, and we will do our best to keep everything local, as we always have here. Porter obviously has a tremendous impact on this community's healthcare experience, and we're very passionate about this work that we do here. We're grateful that you've taken the time tonight to come out and listen and share your perspectives. Before I turn things over to Dr. Hammery, I'll just share that Porter has also seen the initial results of the study, and as with tonight's presentation, we'll take the next couple of months to review the data and recommendations moving forward here. And we'll do this really through the lens of the patient. Really what I'm saying here is that all the decisions that we make moving forward need to be able to improve the care that we provide here to the community. We need to be able to ensure that we have the right services, that we have updated facilities, updated equipment, and the right people, quite frankly, in place to take care of this region well into the future. This isn't just all Porter's work, as you're hearing and you're going to hear. This is going to be a partnership between AHS, with the Vermont Care Board. Porter's tied closely with community partners as well. And whether they're part of the health network or not, it doesn't matter. It's going to take everybody to make improvements here. Our ability to integrate and partner effectively really is going to pay dividends, and in some cases already is paying some dividends in addressing access to services, addressing already improvements in patient experience. And we have worked very hard over this past year working at creating efficiencies that generate cost savings and reducing waste so that we can meet our demands here locally, as well as have future capacity to invest in our facilities in the coming years. So we appreciate everybody's partnership here, and interest in this work, and really look forward to this conversation tonight. So with that, I'll turn it over.
Can you hear me? No. Okay. Well, I apologize for sitting down. I'm not good at standing for long periods, so I hope you'll forgive that. Appreciate all the comments, and thank you all very much for coming, because the purpose tonight is to talk to you as the Addison County and Middlebury communities, and to report to you what we heard from you, and then to do some discussion around what the issues are and what we might be able to do in the future. So we're here to really fulfill some of the mandates of Act 167. In brief, the legislature said these mandates are to conduct a data-driven, patient-focused, community-inclusive effort to assist Vermont's hospitals to reduce inefficiencies, lower or constrain cost growth, improve population outcomes, reduce health inequities, and increase access to essential health services. Our overwhelming team is here tonight to present and to answer your questions along with the other folks that you heard from and other groups present. My name is Bruce Hammery. I'm a physician with over 50 years of experience in practicing and teaching medicine, hospital and health system administration, and healthcare consulting. My colleague in this effort is Ms. Elizabeth Sutherland, a partner in the firm of West Monroe and an expert in health inequities. And unfortunately, Elizabeth wasn't able to be here tonight. We've been ably assisted by Ms. Irene Way, our engagement manager who's here, and by Ms. Melissa Kowalski, our consultant. As Owen noted, my team and I began this journey to examine the healthcare system and hospitals in Vermont 11 months ago, in August of 2023. We have spoken with and listened to over 2,000 Vermonters from all hospital service areas in the state. In this journey, we've also been greatly assisted by the staff of the Green Mountain Care Board, Ms. Marissa Melamed, Ms. Harold Watson, who's here, and many others. We've also been helped by many leaders and staff throughout the Agency of Human Services and by Mr. Mike Fisher and his staff at the Office of the Healthcare Advocate. Mr. Mike Del Treco and his staff at the Vermont Association of Hospitals and Health Systems have been especially helpful. Another consulting firm, Mathematica, and a team led by Dr. Arkaditya Ghosh, has performed many of the data analyses we have used to develop options for changes in healthcare delivery in Vermont. These have been presented to each hospital and its board. These options were then amended based on our conversations with the hospital and its board. We're going to try this. There we go. As you can tell, my grandchildren are more adept at this than I am, so please bear with me. So we want to accomplish 4 things tonight. 1, to report what you and other Vermonters have told us about your lived experience with healthcare. 2nd, to explain the problems facing Porter Hospital, your community, and the state as a whole. Most of these are beyond the control of the hospital. We will show you what some impacts might be on your community and the Vermont health system writ large. 3rd, we want to share at a high level what some of the options are that could be used to address the current and future projected healthcare needs of your community. These options will apply to most hospital communities, but not necessarily to everyone. 4th, Most importantly, we want to set the stage for your active participation as individual citizens and as a community in the effort to transform healthcare in Vermont. As noted, this process will be led by the Agency of Human Services, supported by the Green Mountain Care Board. This is the next step in fulfilling the legislative mandates of Act 167. So this is what we heard from you all when we spoke, I think, electronically in October. And you heard some of this from Mr. Foster. Many individuals don't go to care because the premiums and out-of-pocket costs are too high. Drug costs are high, and it's the complex ones that are most expensive. I think several of us can testify to that. Getting the coordinated care that integrated electronic health records should provide is not here yet. I will note, I think the Porter folks have been making progress on that, so hopefully you'll see some of that soon. I find that insurance coverage, Medica in particular, has extremely poor coverage of estrogen options and others. Now, health numbers are increasing and it's posing a risk to staff, certainly true across the country and across Vermont. Practices are overwhelmed and patients are sent to the emergency room. Patients need in-home care, but practices are too overwhelmed to do so. So that's something we'll talk about shortly. So we heard similar things from other areas around the state. Some other things that were mentioned were housing as a problem both for Vermonters who are unhoused or who live in insufficient housing, a place without heat or electricity. A problem for recruiting people to Vermont, whether they're medical professionals or workers. Affordable housing is a problem. Transportation, big issue, both for people to get to and from the doctor's office or the pharmacy or the emergency room, but also to get people between hospitals in a timely way. Premiums and out-of-pockets are too high. Nobody tells patients about financial services or campaigns available to support broader health and social needs. I would note the legislature, I believe, passed a law earlier this year that people have to be notified about financial counseling in multiple languages, which is an equity issue, clearly, and so forth. So common problems, also common in many parts of the United States. Okay, so let's set the background for your current experiences of healthcare. As noted, all Vermont communities are facing significant challenges to healthcare access, equity, and affordability. Access and equity challenges are shown on the left, the affordability challenges on the right. Difficulties are in getting timely appointments for doctors and surgery. Heard clearly experiences of 6 to 18 months to find a primary care doctor, 12 months plus to get cataract surgery, and so forth. And as Owen noted, we did a study with the Green Mountain Care Board and I think the Office of Financial Regulation at the time on access 2 years ago, or 2.5 now. Certainly has not gotten better. Transportation, as I noted, is an issue, and affordability certainly, as we'll show in terms of insurance premium increase. I know Blue Cross has just announced another large one. Now, where's that? Okay. And so we'll delve into the insurance issue in a bit. But major changes in the way you get health care, receive it, and it's delivered are going to be needed. And one of the issues for you all to think about is what needs to happen and how you can participate in that process. And so we'll talk more about that. Okay. As Owen noted, In fiscal year 2023, 9 of the 14 hospitals in Vermont had negative operating margins. An operating margin is like the balance in your checking account. It reflects the income from patient services minus the expense of providing those services. If you include the 2 additional Vermont hospitals in the red in fiscal year 2022, 11 out of the 14 hospitals in the state that had negative operating margins. This makes borrowing money expensive and difficult for the hospital, and the financial sustainability of the hospital problematic. I must note that all hospital directors and their staffs are working very hard and taking measures to address these issues. So this is not going unaddressed. Not-for-profit Vermont health plans are also not making money. They are tightly regulated, and their premium increases are driven by the cost of care paid on your behalf to providers, hospitals, pharmaceutical companies, and others. They are also required to maintain certain levels of reserves to ensure their ability to pay for the care you require. And these reserves are reaching levels that are alarmingly low. Now, Vermont hospitals and others are facing a lot of challenges in this, and part of the reason for these bad numbers. These challenges include the inability to recruit staff, whether it's due to a national shortage of physicians or other healthcare workers, or to a lack of affordable housing in Vermont when they can be identified. So I've heard stories around the state of hospitals that say, look, we recruited a doctor or a nurse or a lab tech or radiology tech. They came, they worked 3 months, they lived in a hotel, they couldn't find a place to live, they left. And so it's an issue that, like I said earlier, that affects not only Vermonters, but also the people of all sorts that you're trying to recruit here to work. A major issue affecting small communities is the number of doctors in a specialty that must be recruited to provide an acceptable call schedule. Call schedule is how many nights out of the week are you responsible for going to the hospital or taking telephone calls. The community must also have enough patients to support that many doctors. So, as an example, 40 years ago, a call schedule was 1 night and 2. You were on call every other night. When my grandfather practiced, it was every night, right? Not anymore. The current expectation for a call schedule is 1 night in 4 or 1 night in 5. So what that means is if you want 1 cardiologist, you generally have to find a way to support 3 or 4 or sometimes 5, which means that you need a big enough group of people to need that many doctors. Okay? Now, what's the part of the solution to that is you do what Porter's done and join a larger network and get rotating coverage. Other hospitals around the state are trying to do some of that to share physicians, but that's a big issue all over the country. Okay. Many hospitals are old and need to replace their air conditioning, heating units, elevators, and so forth, and they've not been able to make the needed money from their patient revenues. Some surgeries done at hospitals are done too infrequently for the staff to maintain an adequate proficiency. Many of these require not only expertise on the part of the surgeon, but also from the anesthesiologist, the operating room staff, or they may need support from an ICU or other specialists. Supporting these teams with the staff and equipment necessary will likely require hospitals to combine some surgical and medical specialties in ways that support regional access without requiring people to travel to UVM or Dartmouth or Albany or Springfield or Boston. Many hospital resources are also consumed by people who do not need the services of an acute care hospital. These individuals may be waiting for transfer to a mental health facility or a chronic care facility. They may need a place to live or the services of a home health agency to be discharged from the hospital or from the emergency department. The hospital is not paid for these people because their care is, quote, no longer medically necessary. They also occupy beds and take nursing time that could be used for other patients who do need an acute care hospital. On the financial side, the costs of the people who work in hospitals and the drugs and supplies needed to care for patients are increasing at rates higher than the rate at which the hospital is paid. There have also been 4 unanticipated changes in federal policies within the past 6 weeks that will affect either the cost of health care or potentially access to health care. An imposition of a tariff on all medical products produced in China is one example. This tariff will go from 0 now to 7.5% in 2025 to 25% in 2026. This clearly increases the cost of supplies. I would note that one of the presidential candidates has proposed a tariff on all devices and services, all things not made in the U.S. You need to know that many of our drugs come from India or France. Many of our medical devices, x-ray equipment, that kind of stuff, comes from Germany. So think about what a 10% or 20% tariff on that would do. Secondly, there's been a requirement to increase nursing staffing in skilled nursing facilities. I mean, it's the right thing to do. Improves quality, but it will increase competition for a group of people in very short supply. Third, the cut in Medicare payments was announced, a cut of 3.5% to doctors. So if the hospital employs doctors or doctors in solo or in private practice, that revenue goes down. That may make access more difficult. Fourth, the Congress took what I would call a meat cleaver to home health agencies. They were, I think, appropriately upset that for-profit home health agencies were making too much money. Unfortunately, they took a 7.5% cut across the board, including to the VNAs and the not-for-profits. So that will make staffing and getting people home more difficult. And the point of this is simply that I think to what Dr. Levine said, that we live in a larger country that can't always predict what's coming down the hill. And I've said to the Green Mountain Care folk and the hospital folk, I doubt that any of those 4 things are in a currently submitted hospital budget. Okay, so think about what that means to the predictability of a business if that's what you're running. Okay. Okay. All right. So, every commercially insured Vermonter's cost for health care has increased markedly over the past 6 years. On the left panel, between 2018 and 2022, the median increase in household income for Vermonters was 22%. These costs, the cost of, in the middle panel, the Green Mountain Care Board approved hospital requested increases in charges of 38% over that period. And on the extreme left, you can see that the cost of a benchmark plan through the Blue Cross increased 108%. So if you look carefully at that, in 2018 it was $18 more than Massachusetts, and now it's about twice. So not enough change in wage and income to keep up with costs and the health premiums. Steps must be taken Plans must be made and implemented to change these rates of increase. So how have we approached this? Well, I'm a doctor, we do what doctors do. We used interviews and data to make a diagnosis. We used tools and data to make a prognosis, a forecast of what the future might look like given certain assumptions, and I'll go through those in more detail. We then developed and identified treatment options. Some were drastic, and all may require substantial change. You, as the patient, get to make the choice. Now, you do that with your hospital board, and for you, I expect the assistant board of the UVM Health Network, because they have the fiduciary responsibility to help get this fixed, and they're the folks that decide what goes on in the hospital along with the administrator. Okay, and that will be part of the process that the Green Mountain, that the Agency of Human Services will use. Okay, so we listened to you and other communities. We took a history of your past and present illness, reviewed your symptoms, and so forth. This shows the many people and groups we have interviewed and listened to. These have included not only hospital leaders and boards and communities, but also the many healthcare professionals who serve you. These have included dentists, physical therapists, mental health counselors, doctors, nurses, pharmacists, EMTs, home health agencies, nursing home administrators, and many others. We have spoken with many state agencies and departments as well as legislators. We have also met with a number of community and state organizations advocating for those suffering from health inequity and those with special needs, whether those are mental health needs, physical needs, or those with specific illnesses needing more specialized care. We have sought out groups with unique language, ethnic, and gender identity characteristics. We performed some tests, mathematically did projections of total population in Addison County. And I want to call your attention to a couple of things here. If you look at this, overall, this is projecting roughly an 8% population decline, roughly from 31,000 in 2020 to about 29,000 in 2040. So that is general across the state, except for Chittenden County. Yours is a little less severe than many others. There are others that are going down 10, 15%. Okay, now within that, note the two upper blue bars. You young people in the room that are between 65 and 74 are going to double in proportion over the next 15 years. Okay, you're going to go from about 12% to 24%. If you're in that 75 plus year group, like I am, and there aren't very many of you out there, one or two, you're almost going to double. Okay? So what you're looking at is right now, you have about 20% of your total population, roughly 6,000 people, that are over 65. In 15 years, you're going to have almost 35%. Okay, 1 out of 3. And as Owen noted, that changes what you need in a community. I mean, you need assisted living, you need more attention to home-based services, and AHS does have some of that available. Okay. You need memory care, and you need other services that are, I won't say peculiar, but maybe unique to older folk. The other thing I want to call your attention to is that dark gray bar. Those are the working age folks. So this is you young people between 20 and 64 who are working and can buy commercial insurance. And as you heard from Owen, those rates are going up, and what goes on is that the bulk of payment in most hospitals is Medicare and Medicaid. Medicare generally pays about 85% of the cost of that care. Medicaid more typically pays 65 to 70%. Now, a little higher in Vermont. But still, there's an underpayment. And so typically what happens is the hospitals get more money from the commercial insurers to make up that difference. And that we think is part of the reason for some of these increases. And so we also think, and have seen elsewhere, that part of that solution is you move care out of the hospital. You move it to the home, you move it to the community, you invest more, as Dr. Levine noted, in preventive things, right? Checkups, primary care, and so forth. Okay, but the point of that is that that's a 31% decrease in the proportion of people who are going to be paying commercial rates. And what that means is if you need to generate an absolute number of dollars to support health care in the community, those rates are going to go way up, okay? And that can't happen. Okay, we also use this information to give data to the hospitals on what they could expect over the next 15 years in terms of number of cancer cases, and people admitted for heart disease and strokes and that kind of stuff. So you can also take a look at what those needs might be. Okay, so no secret. The least expensive place to receive care and prevent the need for more advanced and expensive types of care and sites of care are at the top. Your home, a group home, facilities for mental health treatment, substance use disorder, group homes for whatever are needed. Enhanced capabilities and staff for primary caregivers, mental health, and substance use disorders are needed. Now, when you don't have those or don't have enough of them, as is the case currently in Vermont, people have to seek care in the emergency room. And when they get there, they are often sicker than they would be because they haven't been able to get in to see the doc, or if they could get an appointment, haven't been able to get transportation to go to the doc, or if that happens, they haven't been able to afford the medicine. So the result is they're sick. And sometimes that means they need to go into the hospital, other times it means they're so sick they need to go to a good place. And the result is an inconvenience for the patient and her family, and a bigger bill for care. Okay. So, using this information, analysis, and reports from prior state commissions and consultant reports, and I would say I probably reviewed 30 of these things over the last year, we constructed a financial prognosis or forecast. This makes certain assumptions which we have tested with many people. Not everyone agrees with these numbers. I want to call your attention to that. Shown on the left are the increases in charges requested by Porter Hospital and the rates approved by the Green Mountain Care Board. So you see in that top set of boxes, over a 5-year average, a 5-year period, 2018 to 2022, the hospital requested 1% rate increase, got 0.8. And in the most recent 2 years, requested an average of 5.2% and got 3.3% approved. So not bad. And you see also that in the graph on the right, you look at that gray bar. To the left of it is the prior performance of the hospital. This is percent operating margin. It's all above zero. Okay. In the gray bar, we use 2023 as the base year to project. We chose 2023 because it's after COVID sort of washes out and after all the federal funds to support hospitals wash out. We then took a set of assumptions, and these are key. The assumption we used for our projections were a cap on increases in hospital prices of 3.5%. This is the current cap for revenue increases set by the Green Mountain Care Board in its effort to slow the rise in healthcare costs. Estimates of the ongoing increases in hospital expenses nationally range from 5 to almost 8%. My going in was 7. A recent report by another consulting group said they expect price increases next year to be 8%. Nonetheless, we talked to all the hospital administrators. Several said, well, we think we can control this to 5%. So we used 5% increase. Now, no surprise, right? Revenue is fairly fixed. Costs are going up, margins are going to go down. Porter is the only hospital in the state that in 2028 still has a positive margin. It's about 1%, so off to the side there. Everybody else in the state is significantly negative, and I'm talking minus 17% for some. So, we'll get back to that. I did, by the way, give a presentation to the Green Mountain Care Board about a month ago, and I showed a graph like this, but it has all 14 hospitals on it. And if you want to go to the website, you can certainly see that. Okay. This slide shows the increases in total hospital revenues statewide approved by the Green Mountain Care Board over the past 10 years. The small numbers at the top of those bars are in billions of dollars with a big B. And you'll note that in 2013 it was $2.1 billion, and in 2024 it's 3.6, about a 74% increase. Now this is statewide. That is it all in. At the bottom, you see the percent of the billions that were approved by the Green Mountain Care Board, so virtually 100%. Okay. So the hospitals got virtually all of what they asked for. Not every hospital, as I showed you before, got everything they asked for, but when you're talking billions, as some of you may remember Senator Dirksen, who said billion here, billion there, you're finally talking real money, right? Okay. So this is Blue Cross Blue Shield of Vermont. And what you see here are the underwriting losses suffered by Blue Cross Blue Shield of Vermont in 5 of the last 6 years. Underwriting losses, as I noted earlier, represent the amount they pay for your health care that exceeds the amount of income they get from your premiums. They are a tightly regulated entity, and the Green Mountain Care Board regulates their premiums. The Office of Financial Regulation in the state regulates their financial health and their reserves. And you've probably seen a report from Burlington in the last day or two about that. I will mention I was on the board of Blue Cross in Massachusetts, and I'd be going nuts with these. Okay, these are very bad, and I think to Owen's earlier point, you're not going to get more money from the insured. Right? So you've really got to think about how you redesign the care. Okay. Now, every hospital uses these levers to improve their operating margins and financial health. This is what they teach you in hospital administration school. This is what some of my partners do to go out and work with health systems. To increase rates and therefore payments from insurers. As noted, the principal payers for most hospitals are Medicare and Medicaid. Together, these usually account for about 80% of total hospital revenues, and we talked about the underpayments. For Medicaid, payments are set by the state legislature and the Agency of Human Services. As I noted, these payments only cover about 65% of the costs, and in Vermont, federal matching funds pay about 70% of those dollars. They are dispersed through the Department of Health Access of the Agency of Human Services. And we talked about the use of commercial insurance to make up for the underpayments. They can reduce operational costs or cut expenses. In many cases, small rural hospitals do not have the capability to do this because they are already minimally staffed. And staff is one of the major drivers of expense. Usually about 65% of a hospital's expense is people. Now, if you think about a small hospital, you're covering your emergency room with one doc, 2 nurses, a couple of MAs, you have a radiology tech on call, you have a lab tech on call, and whether you see 5 patients or 35, you've got that number of people, right? So that you really, for some parts of it, you just can't cut expense. And so that lever doesn't work real well if you're small. The other thing you can do, of course, is increase the volume of profitable services like orthopedics or cardiology. Sometimes you have to cut unprofitable services like pediatrics or OB. Or you can seek support from the state or a granting agency, or hope Elon Musk shows up with $2 billion to give you to keep going. Pulling these levers for most Vermont hospitals has not been successful in getting to sustainable operating margins. So you can't keep doing same old, same old. The system has to change. We therefore made a large effort to see if addressing the problems of potentially preventable emergency department visits, potentially preventable hospitalizations or rehospitalizations, and reducing the number of people who were boarding, who couldn't get somewhere else or get home, would free up enough capacity in each hospital so that people from the community who were having to go somewhere else to get care because they couldn't get into the hospital, if enough of them could come back, and bringing that care and that business back would make the hospital sustainable. Sadly, the measures improved revenue, but increased expenses as well, and did not result in any significant improvement in these projections. So if a hospital was at minus 17%, it might be minus 15%. Or minus 7%, it might be minus 6%, but it's just not enough to make a real difference. We've shared all this with each hospital and its board. And as I've noted, these dollars are not likely, as Dr. Levine noted, these dollars are not likely to come from the feds because Medicare is stressed, Medicaid comes out of the general federal budget and is under a lot of pressure. And it can't come from commercial premiums. You've heard Owen talk about taxes. So if anybody doesn't know Elon Musk, change. There are more headwinds coming, and we've noted federal policy. Okay, so where do we go? Well, as I said, hospitals can't solve these problems alone. They don't control who comes. They don't control where people go. Right? So they're the recipients of everything in the community, but they really don't have a lot of places to get people so that they can get out of the hospital. This will require concerted systems transformation sustained over time. And I emphasize concerted, sustained effort, unrelenting effort. And that's where you are. So, what can healthcare in Vermont look like? What's required? What things are already underway that can be built upon or enhanced? What does charting a path forward look like? First, recognize the current situation and the adverse headwinds you're facing. The Marines would term this adapt. We have discussed some of this. Second, change what you can and build on current efforts to change the way healthcare is delivered in your community. Dr. Levine has mentioned some of these. We'll show you some. The Marines would call this survive. Next, design and implement ways to improve access, equity, and reduce the cost of healthcare for your community. The Marines would use the term overcome for this. Done in the right way, these changes can ensure that the redesigned services will have both a stable financial and operational future. Abraham Lincoln said the most reliable way to predict the future is to create it. The system you will design here with Porter, with other communities, other hospitals, to address your current needs and those of the others, will need to address these issues among others. This is the most recent community health needs assessment that Porter did with you all. The mission of the hospital and vision on the left, and the needs that you identified: housing, access to both health service and mental health service. So, top three, housing certainly the top one on my list. And so these are efforts that are underway, and we'll show you. These are some of the things that Porter is currently engaged in with many of you. Integration with UVM, getting the electronic medical record, helping with patient coordination. I'll note, just told that they've got an artificial intelligence thing that's helping write notes and taking that burden off doctors, which is good. Cooperate in providing space for the open door clinic and screenings to address social determinants of health. Quality care recognized, more investment in primary care, Blueprint for Health, supporting community health teams, and education on diversity, equity, and inclusion, recruiting a number of specialists, and planning an investment in the emergency department to increase the size and capabilities, improving access to specialty care. So a number of active efforts to build upon and take into consideration as you redesign. Okay. Changes at both a hospital and a state health system level are required to meet both current and future needs for health care. These fall broadly into the 5 areas shown. One is embed updated and modern information technology in hospitals, offices, homes, and other places where people receive care. Note homes. Provide housing for Vermonters and others moving into the state. We talked about this. Housing is arguably the most urgent need Vermont has, not only to address inequity, but also to provide a safe place for people to receive appropriate care outside the hospital. Transportation for people to and from medical care, pharmacies, and other places needs to be enhanced and available in the late afternoons, evenings, and on weekends to help people with urgent care needs get to and from the urgent care center, the doctor's office, or the emergency department. Emergency medical services, which are largely staffed by volunteers, need to be combined, linked tightly to the hospitals, and made into a full-time professional workforce. This would create additional jobs in the community and allow the provision of patient transport to and between facilities using vehicles other than a mobile ICU. In the planning process to be described shortly, hospitals and communities will need to design a system in which there are regional referral centers, each containing an area having a sufficient population to support the physicians, the staff, the equipment, and other services needed to provide high-quality, efficient care for specific diseases or conditions. Work we have done and shared with each hospital suggests that there is and will be sufficient need that some of these centers could be supported without people having to travel to Burlington, Dartmouth, Albany, New York City, or Boston. In the system to be developed, all providers, primary care providers, specialists, dentists, EMT services, hospitals, social care providers, and so forth, should have their payments linked to common goals: access, quality, efficiency, appropriate use of resources, and equity. Let me be clear about efficiency. This means doing the right thing at the right time, not forgetting to give a vaccine or not ordering a more expensive test when another may be adequate and less expensive. As noted in the green, the goal of a redesign is to provide the most appropriate and needed care in your home, in the community, or close by. So there are many potential options. Some are listed here. I've said in other groups, we have a list of about 120 of these. And they'll be in a final report that we owe the Green Mountain Care Board this fall. Your comments on this presentation and thoughts is going to be important in this process, and that's why we're going to have Q&A in a few minutes. But I note here, telehealth, which Porter, a number of other hospitals are using to get neurology or cardiology or psychiatry help to the emergency room staff so they can make treatment decisions. Increased use of information technology for remote monitoring. Now, I call your attention to this, okay? You can measure your arterial oxygen with this thing in real time. When I trained in 1971, you had to draw blood from an artery, send it to the lab, and an hour later you knew what the guy's oxygen was, and then you could change the ventilator setting. Okay, so you've got this, and you've got things that monitor your EKG and your heart rate, and you've got monitors that'll tell you what your blood sugar is. So all of those things that were not possible 10 years ago make new ways to deliver health care possible and cheaper. So that's another thing that I think you really want to keep in mind, is that and we'll talk more, there is a national movement to move care back to the house. Now, you can't do that with surgery, but you can do a lot of recovery, right? So I'll give you an example. I trained at one of the world's centers of heart surgery. One of my deans did the second heart transplant in the world. In those days, if you had a coronary bypass, you spent 2 weeks flat on your back in the hospital. You were treated like you had a heart attack. You then spent 3 months in rehab to get all the muscle mass back that you'd lost from spending 2 weeks in the hospital. Okay, so now, 6 hours after the surgery, your endotracheal tube comes out. You sit up on the side of the bed. Several hours later, you get a soft meal instead of a lot of, you still have some IVs, but you're being fed. You dangle, you start walking, and on the third day, you're out of the hospital. Okay, and the rest happens at home. So changes in the way this happens. If you had a hip or a knee done, it's outpatient. It used to be a week, 10 days in the hospital. Okay, so there's a lot of movement in this direction that I think you can take advantage of, and the UVM people and the Porter people and others, I think, are prepared to help with this. Rural outreach programs, primary care hours. Now, a lot of places have tried to increase their evening hours, weekend hours, but they've not been able to staff the nurses. So they had to pull that back. EMS we've talked about, availability, some way to keep track of who's got what capacity in the state. That was something the state did during COVID. Came to an end the end of May. The emergency room folk tell me they can spend 6 hours or more on the phone, call 19 different hospitals around the state, and Dartmouth and Springfield, Massachusetts, and so forth to find a bed, and then call up to 30 of the 76 EMS services in the state to find an ambulance to take the patient from their ED to that hospital. So that's 10 hours of somebody sick in an ED. And there are some ways, I think, to fix that, we'll put in a report you all will get to hopefully help make happen. We talked about regional centers. The hospitals are working on a lot of cost reduction measures. Porter, of course, has taken the path of joining a larger network that combines some of those things. A number of smaller hospitals have just signed up an agreement to form a company to do a lot of that behind the scenes. The last one I want to mention is that there are folks in the population that are identifiable that have extreme mental and physical and other health needs. They account for about 14% of the population. They account for 30% of all dollars spent by Medicare and 32% of all dollars spent by Medicaid. That's a group as known as the dual eligibles. There are people who have such severe illnesses that they get money, their health care is paid for both by Medicare and Medicaid. They need special attention. The only program in the state that I'm aware of currently that does that is SASH, and they only have a couple of thousand folk in that. You have roughly 31,700 and some people. And if you think about 30% of Medicaid spend and, 32%, 30% of Medicare, that is a group that if you really gather around them and take care of them, you can reduce a lot of these healthcare costs that then get shifted into the commercial premiums. Okay, so, as Dr. Levine said, as Owen said, there are opportunities here. There are opportunities to do better things for people and to reduce healthcare costs. Okay, so here are the major steps in designing the future care for your community and for Porter Hospital. The first step is to make the decision to change. I hope this presentation and our sharing of the information has convinced you of this need and its urgency. In this process, you and many others will choose among the many options some of which we presented, and will construct some of your own. These options will then need to be examined for their impact on the community and on their financial stability. Planning sessions and budgets to support the final options and plans will need to be made and the plans implemented. As noted, the Agency of Human Services, with the support of the Green Mountain Care Board, will lead this process to gather the communities, providers, hospitals, and others desiring to plan their future. They will assist you in choosing among the options for repair mechanisms, help evaluate the effects of those on your community health and for their sustainability, and then help to implement the changes. The Agency of Human Services and its many components have numerous services available and are at various levels in testing and implementing others. Many, but not all, are listed here. Time does not permit an exhaustive review of these, and this presentation and this slide is available for your review and comment. I gave this the presentation on a lot of this June 19th, which is on the website. Free to go look at it and certainly offer comments there as well. I would call your attention to the large efforts directed to mental health and substance use support and to elderly care support. Major efforts are also underway to improve the infrastructure for transmitting medical data and to streamline the licensure processes needed to get new healthcare professionals into Vermont and allow them to practice. The Green Mountain Care Board has also had many efforts underway to try to constrain the increases in both medical costs and insurance premiums. These are shown here. Owen noted the Act 167 project and Dr. Holmes' involvement in that. I would also note they commissioned and had a report done on the state of rural health care several years ago. The legislature has also been working to address some of these issues. They have approved in the past Medicaid funding increases. They have enacted a law to eliminate some requirements for pre-authorization for health care. And they have approved funds for housing as examples. Okay, so where do you go next? How do you get involved in this process? You can attend community meetings and planning sessions. You can monitor the websites of the Green Mountain Care Board and the relevant units of the Agency of Human Services for updates and for opportunities to comment and to provide feedback on their plans and activities. You can support the administrative support of Medical Center and its board in making what may be difficult or painful choices. You can speak with their legislators and the appropriate state agencies to express the need for making the laws and funding needed to put your changes in place. Now, I will note, a lot of what you're going to have to do is make choices among programs and how to reallocate dollars. The state budget, all in for health care in 2020, was $6.4 billion. If 10% of that is identified and can be redirected at $640 million, you can do a lot for that. Estimates of waste in health care start at 10%. Some go up from there. I've heard 30%. Okay, I have a friend who looks at the way clinical programs are delivered. He thinks waste in that area is 80%. I don't think that's true, but probably 40%. Okay, so there are options. And I will say the state has started a number of things over the last number of years. Not all have worked. Okay, so you're going to have to go and look. Okay. So, change will not happen by itself. Designing and implementing an improved, sustainable health delivery system for this and other communities will require the active participation and engagement of everyone in this room, of other communities and hospitals, and of the state of Vermont. As shown by this photo of an Amish community raising a barn in Lancaster County, Working together, much can be accomplished. You have many more tools available to you than the farmers in the picture do. This is all handwork. Broad changes in custom and practice are also required across the state. What affects one community affects many others. An unplanned, unanticipated disaster in one community, whether a flood, a pandemic, or an unanticipated hospital closing, has impacts throughout the state. As I discussed a short time ago, the financial projections for many hospitals in the state show diminishing financial stability over the next 3 to 5 years. Therefore, your time horizon or runway to design and begin to implement the needed changes is short. The airplane runway on the left is 2 miles long, 10,000 feet. The runway on the right is on top of a mountain in Bhutan and is 900 feet long, 300 yards. It has a cliff at one end, and you can't see at the other end is an aircraft hangar, an airplane hangar. I have been to that airport. I did not fly in. There are only 8 pilots in the world certified to fly into that, and only when it's clear. Okay. Now, your runway is longer than 900 feet. It's not 10,000 feet. Okay, I will tell you a story. I live in a small town in Massachusetts, about 3,000 feet. My town argued for 5 years about whether to bring fiber optic internet into town. Okay? Now, y'all don't have 5 years, right? So this process, which I think has already begun, the Secretary of AHS called a meeting of all the hospital people 2 weeks ago or so. So the process needs to start, proceed in an orderly way, make reasoned decisions with your input, and get this stuff started, right? And you're going to have to do it largely without lots of new dollars. Some will be needed, but you're not talking hundreds of millions like. Okay? So I thank you for your attention, and I'm going to turn it back over. There he is. Where's Dr. Whitmire? Yes. So, Dr. Whitmire, any comments, and then I'll start taking questions.
I appreciate the doctor, but I'm not a doctor. I'm just a little administrator. So.
You look like a doctor. Act like one.
So thank you, Bruce, for all the work you're going to do this, and we will certainly look into all this data and recommendations going forward. We look forward to working with everybody locally here as well as everybody at the state to move these recommendations forward. The work getting done at Porter, I think we've done a lot of good stuff already. We've got a lot of things started, and pieces of what Bruce had already gone through just reinforces the need to continue that work. So again, thank you for the presentation.
So, questions? Yes, ma'am. We'll get you a microphone just a minute.
Yeah, thanks so much for your presentation. I know this is ongoing, so I had a couple of questions that I thought would be great for you to take a look at as we go forward. One is, we know that administrative costs take up about 30% of healthcare spending in the United States. Just look at University of Toronto Hospital, 7 million clerks, Duke University Hospital, 1,600 million clerks. Let that sink in. So, can you look at the admin costs and billing costs of each of the 14 hospitals? Secondly, and I would hope that you would look at the impact of a large monopoly in a small state on prices. Now, this has nothing to do with, malevolence or anything. It's not like people sit down in the basement and say, hey, let's raise the prices. But we do know that hospital consolidation does need to have a prices, and I think it would be great for you to look at that. We are a small state with a large monopoly on Maine, but if you could take a look at that. Second and third, I'm so happy to see you mention the importance of primary care. We have had a universal primary care bill in the legislature for years. Can you look at what the impact would be if we made primary care a public good? That would take it again out of this whole insurance company thing. It would also make it great for providers in underserved areas, because you have a sustainable rate of reimbursement from the single pool, as opposed to people in poor areas, being dependent on Medicaid payments. I think we do a lot. We've heard mantras for decades, I want to say, about the importance of primary care. If you could study the impact of making that a public good on our costs, that would be wonderful. I think you have the capacity. I know you've got about $1.1 million for this process. Hopefully you can do it. Finally, I think there's some wonderful ideas here about how to better integrate healthcare needs of communities with support services such as transportation and the like. I do want to point out that if we really want to plan for the needs of our communities, it's much easier in a publicly financed universal system where you can have real labor budgeting, and where the administrative costs are greatly reduced, and you can actually attune services to the needs of an area. Now, I know we've been down that route, but we've never really dispensed with it in Vermont. We've just pressed the pause button. So, I guess that's all. Those are the questions. I would also say, just to the audience, we can keep kicking the can down the road and not create a publicly financed universal system, and our costs will continue to go up, our access will continue to get worse, and I don't want to see that happen in Vermont. And finally, in terms of days in hospital and home care, of course we don't want to get home when we're in the hospital, but I would point out that all other countries, or as Bernie says, major countries that have universal systems have actually longer hospital stays and lower costs per capita than we do. So I would urge us not to simply say, we got to kick people out of the hospital when they're not ready. I hear a lot of talk about that in, I don't know, a policy community. But, here in Italy or Germany or someplace, they stay longer. Doesn't mean you have to take 10 days for 50 places. But if you could actually look at that again and look at the assumptions behind that. So I don't want to take up all the rest of the time. Those are my questions, and I hope you can look at them. And thank you very much.
Thank you. I'll just note, when I've gone to Sweden and Norway, they have a high tax rate. So that is not paid for in the way we pay for our care. I take your point, and we're not suggesting anybody leave the hospital before they're ready. But I will say that there are a number of programs around the U.S. that can get people from the emergency room to their home, right, without having to go to the hospital. So take your point. Thank you for the questions. Others?
I'm all the way in the back here.
Yes, sir.
Thanks for your presentation. One thing we haven't talked a lot about here, and pardon me if I missed another meeting, are the incoming costs of the consumables to the healthcare delivery. So you can redistribute the patients all you want, but they're still going to use the Band-Aids and the bags of saline and all that kind of stuff. So the question is, what percentage of the hospital or healthcare costs are the tips and tubes and bags and bottles and that kind of stuff that the hospital has to buy or the home healthcare workers have to buy? And what's the profit margin from India to Vermont? Can Vermont negotiate directly with Siemens for X-ray machines and directly with drug companies in India, or do we have to go through 10 middle people to get there?
It's a great question and a great point. And I think some states are trying to set limits on the prices of some drugs. Okay, and you're right, there are a lot of what I call middlemen in this. Of course, everybody wants a 5% or 10% profit margin, so it goes up the stream. There are some companies in the U.S., there are two that I'm aware of, that basically offer drugs at cost plus 5% or something. One is a company run by a man named Mark Cuban that does that to consumers. There's another company that was formed by a couple of hospital systems and others joining in, which is building their own drug manufacturing plant in Virginia to provide at cost the generic drugs to hospitals and healthcare providers. So your point's right, there is a markup. It's less, a little bit, the markup to the consumer tends to be less outside the hospital. Okay.
Thank you.
Others?
Thanks so much. I really appreciate this conversation and that we're bringing it to the local level and giving an opportunity for folks to understand and weigh in. Today, I have a bit of a statement and a request. So my name is Rachel Lee. I'm the Executive Director of the Counseling Service of Madison County. In full disclosure, I'm also on the board of Porter. And through Porter, I serve on the Finance Committee for the Union Health Network. I'm also on the board of our local federally qualified health care center, Mountain Community Health, based in Bristol, which provides primary care, substance use services, and dental care, primarily to people on Medicaid, one of the few Medicaid providers of dental care. Well, I want to give a shout out to Porter. We're incredibly grateful for the care and access they provide and they continue to work on. While I understand the larger issues beyond the hospital's control, Porter has been an excellent partner to CSAC, supporting and caring for people who frequently show up in the emergency room at some of the worst moments of their lives. The staff and administration are accessible, they're collaborative, and committed to improving people's healthcare experience. Our strong partnership with Porter helps us transition individuals from the emergency department to appropriate treatment quickly, and we work hard to collaborate and communicate effectively with their primary care providers, including pediatric practices. We need a strong local hospital, and I appreciate Porter's efforts to keep care local, accessible, and timely. Act 167's intent is, how I understand, a little more broadly, while today's the focus on hospitals. We want to look at the overall healthcare landscape, including how we pay for healthcare, how we measure what good healthcare looks like, and how people can access healthcare in a more timely way. And what I want you to know is that the pressures mentioned today are also experienced by CSAC and other community-based organizations that provide critical upstream services. So with that lens, I want to tell you a little bit about CSAC. As a designated agency, a DA, we're an integral part of the continuum of healthcare in the state. CSAC offers a wide range of services, including outpatient mental health care, psychiatry, school-based supports for almost every single school in this county. We provide a jobs program, I have more folks here, and crisis intervention. We serve everyone regardless of their ability to pay. We provide community-based services that are often less expensive and more effective in terms of the outcomes we want to see as a community, ensuring people are healthy and thriving in their community. Our emergency mental health team supports people in the community and at Porter Hospital. They're assessing people for safety and hospitalization needs. I have one of my supervisors here today. More recently, we've expanded our crisis services with Interlude, a mental health urgent care center within the mobile works. And Interlude is another option for people to the emergency department if you're having a mental health crisis. We also have a crisis team that we've expanded mobile crisis. So that team meets people in the community if they're having a crisis, whether they're in the home, in the community, or at school. I want to recognize that we don't do this work in isolation, and we're incredibly grateful to the strong network of community partners and providers like Charter House, Tri-Valley Transit, Madison Housing Work, Home Health, Turning Point, John Graham, Hope, the Parent Child Center, Mount Community Health, and of course Porter. So CSAC employs 275 people, and we're fully staffed. We have about 310 employees. The majority of our staff live, work, shop, and play in Madison County, making CSAC an economic engine for the county. In the past 5 years, we've focused intensely on increasing staff wages, including increased pay for clinicians, psychiatry team, residential staff, of which we have 8 residences throughout the county, and developmental services. These wage gains have been possible because of the support of our legislators. Well, we recognize the need to invest in mental health and developmental services. But despite these gains, we share similar struggles with hospitals. At CSAC, our turnover rate is 11%, which is the lowest of any DA, but we continue to struggle with recruitment. Within our developmental services program, we have a 30% vacancy rate, a rate which has improved from 50%, but remains awfully high and a significant challenge. We also face staffing difficulties with our residential programs, school-based services, and crisis services. Designated agencies have been underfunded for decades, with the exception of the past 3 years. Thank you, Middlebury legislators, for their support. And despite these investments, our staff struggle to make ends meet. Many of our staff rely on subsidies for fuel, food, and housing, despite having a college or advanced degree. Many folks are also bogged down with incredible school debt. The cost of healthcare is a significant challenge for us. This year alone, our health insurance rate increased by 20%, representing a 13% increase to our budget. We consistently face double-digit increases in healthcare costs, which is unsustainable for us and our staff. Additionally, inflationary costs, the increasing administrative complexities of running an organization like CSAC, and a lack of consistent and predictable rates make it challenging to run our organization effectively and deliver top-notch care and to be a good employer. So as you continue to think about, in a really holistic way, I really appreciate how holistic your data gathering has been and the many conversations you've had. Our request is you include the voices of staff working within the DA system of care. We collectively support thousands of Vermonters every day. In 2023 alone, we provided over 3.3 million person and family-centered services to over 40,000 Vermonters. Our care and services are effective, they save lives, and they save Vermonters money. Thanks.
Thank you.
Yeah. So my big question with a little ramble to try to orient you is, so how do you shake up the organizational culture within the system so that people are aligned with your mission? I'm a physical messenger, I have doctor, and was at UVM, left 30 years ago, knowing that my career would be done if I stayed here. And my friends who stayed got nowhere with their careers, never published a paper, nothing happened. They're workhorses. And within 15 doctors, they have 4, okay? Went on practice at the University of Michigan, professor. I teach the leadership of the business school there, and I'm back here in Middlebury with an office across the street from Middlebury, right? That's a funny little town to be in. I love our town and our hospital. But again, I come back and I realize why, if I was happy with this, my career would be done. You know, there's plenty of research that says that what we do in my specialty is of value. I did a study, we got rid of 1/3 of back surgery in Western Michigan. We got an 80% decrease in returns to emergency departments when we included people. But then you look up at UVM and Dartmouth, and actually every place, all the specialists in my field work for an orthopedic surgeon, and they are not equal, they're my friends. But what orthopedic surgeon is going to invest in a doctor who gets rid of 1/3 of the back surgery, right? And what orthopedic surgeon is going to invest in a doctor who takes care of cancer, or develops a long COVID program, that takes care of kids with disabilities? And they're not evil, but you've seen over 30 years that there's been no advance in these very important areas in a state that has the highest social security rate for young people in the country. Right? All those people aren't paying taxes. So the real question isn't my whining about rehab medicine. It's about the guys that are, you've been there, man. The orthopedic surgeons, or the neurosurgeons, or the cardiologists, people that make the money, cost the money, they're valuable people. But they're not going to lose power, because what hospital is going to diss their surgeon? So how do you change the organizational culture to align with what they need?
Well, I guess a couple of things. One of the things we did at Geisinger was we put a physician's assistant under the orthopedic surgeon to do the evaluation. Okay. You know Jim Weinstein? Okay. So you know he put up a big program for spine surgery and cut rates. And there are others, but I think the crux of your question is how do you get people to change?
I get organizations to realign. Rehab docs out there are ambulatory PAs and they
Right.
run out and save money for the system.
Well, I think with a lot of pressure, okay, and I would just comment, I think what you have now in Vermont, and some other places around the country, you're unfortunately at the forefront of small rural populations aging. Okay, so it's not a good place to be, but you've got a planning process, right? You've got some data to start with, you've got a planning process that's getting underway, and you've got enormous pressure because it's just totally broken, right? And it's not in good form. You heard that. So I think it's a plastic moment, right? But it's one of the reasons that the communities need to get together and help do the planning, right? You know, this will ultimately be a decision for the hospital boards, right? That's where the fiduciary duty is. And the state can lead the planning process, the Green Mountain Care Board, and so forth. But at the end of the day, as a guy who served on a bunch of hospital boards, it's the board's responsibility to provide high quality, accessible, affordable, equitable care. And you can help design what you want to see and help the legislature and the Green Mountain Care, or the Agency of Human Services people make it happen. But with what happens at the hospital level, it's going to be a board decision. What happens in the community level, I think will be up to you guys and the Agency of Human Services. Okay? Payment has not been part of our charge. And the efforts that Dr. Levine mentioned around global budgets and a head model and all that is not something we've looked at. And you'll notice those projections only went out 5 years. And that's because after 2026, 2027, nobody knows what the situation's going to be. Okay. So that's all I can say. It is hard to get changes made. Yes, ma'am. I'm sorry. You had a comment, I think. Another comment? Yes. Yes, ma'am.
Hi, my name's Paige. I'm actually an employee over at Porter and live in the community. And this kind of ties into what CSAC was saying about, you know, how their employees struggle. Is it easier if I stand up for you? There you go. And I was just wondering, so given that Porter spent over $18 million the last few years on travelers, the lowest paid of which I think got like $40 an hour, if you guys have considered kind of the role that unions can also play in this and, you know, create a more sustainable workforce. For example, Planned Parenthood of New England and the sports staff at UVM, they had an increase in the number of local, you know, positions held by local staff by like, I'd say 300 people or so once the contracts were in place. So just wondering if you guys considered those will play in it either.
Thanks for the question. We have not tried to deal within the hospital dynamics. Right, this has been a very much broader system overview, and so we've not really considered or taken into account any of the internal dynamics to a hospital. I mean, understanding that travelers are expensive and are, let's say, at least a potential interim solution to a shortage, but one of the things in these recommendations will be the use of other professionals to assist primary care and other groups in relieving some of those shortages. Not so much on the inpatient side, because that's a much more specialized area. But thank you for the question.
First, thank you for being here, for presenting the information, for giving us a chance to weigh in. I have both a cautionary note, and it's not for you, it's for the Green Mountain Care Board and AHS, which is, you showed us that amazing chart of declining revenues and assets that after 5 years, I think, Ford is going to be the only viable hospital. Sounds like, and we're about to enter into, it sounds like this, the head model, which we will be tied into for 9 years, that apparently would really hamstring us in terms of implementing many of the changes that would be really useful. And I realize you said that was not part of your, I wish it were. I wish you could do that, but, so I guess this is, but then I heard Dr. Levine say we have to play nice with the feds or we will make them angry. So that made me a little, it's not what he said, I'm just paraphrasing, but I know there, 80% of the funding that's coming in for our hospitals is federal. And I guess the other comment is the World Bank and the World Health Organization, which created the Nurture and Care framework for developing countries, looks at all of us as working together as equal partners, rather than sort of the adjuncts to help our hospitals stay viable. So it's maybe what you were saying before. I hope you can help us to get to that point where everybody in the community is focused on the well-being and the health of our populations, in which our hospital is a major player, but the rest of us are major players too.
Agreed, thank you. Dr. Levine, you want to comment? I mean, you made a motion over there, so I'm sorry.
This is just a very general comment, nothing specific. Ed was an alert to everyone here that we are moving ahead in the spirit of innovation, in the spirit of responding to the kind of report that you're going to be seeing in its full glory in the fall, I guess. And ahead is one opportunity in the future of how we innovate and how we use healthcare reform. And it's not quite nice with the feds, it is a negotiation with the feds. Nothing has happened yet that Vermont signed a committal letter saying this is our next 9 years. Nothing could be further from the truth at this point in time. So again, that's just, I was trying to provide examples so that people understand that it's not like we've been waiting for a report to understand the gravity of the situation and then do something about it. This has been a very ongoing process for not just months, but many years. And it continues in Vermont at a much, I think, brisker pace than many other states. The other thing I did say, though, is we are part of the United States. So we do have constraints based on all the payers at the federal level and the kind of innovation that we can negotiate with them to try to achieve our goals. I don't want to take it further.
Thank you. My name is Herb Olson. I live in Starksville, and I want to thank the board for listening to Addison County folks here and to the legislature for creating this process. Very important process. I have two questions. First is, I'm wondering if you believe that all participants in Vermont's healthcare system. I wonder if you believe that all participants in Vermont's healthcare system truly believe that healthcare inflation is the #1 priority. I believe, from what I've heard and seen, that the board believes that. I know that we're good at this. Whether or not all participants feel that it's the #1 priority, I say this because back in the 90s, I was drafting the statute that the board uses in their hospital budget review, and everyone believed that healthcare inflation was unsustainable. Then in the 2000s, I was part of general counsel with the regulator, working with the legislature on healthcare reform, and everyone believed that healthcare spending was unusable and unsustainable. And now here we are again, and I'm campaigning, but I'm seeing again, everybody thinks that healthcare spending and healthcare inflation is unsustainable. And I'm wondering, I believe that some people feel that it's the #1 priority, but I'm wondering what you think, whether everyone does. The second question, if I can now, keep my microphone up here. I have a suggestion for dealing with some of the issues not in decoration of the many efforts and initiatives and options that you folks have been putting forward. But I think in addition, and maybe as a first priority, I wonder if you'll consider universal primary care. And the reason is that I think it touches at least a couple of really important issues around cost. First has to do with a vertical, integrated monopoly that tends to, by the research, increase costs. We've been at this for a little while, since the 90s. And so that's one issue that primary care addresses, universal primary care addresses. The other is simply addressing why are we losing primary care physicians, practices, and I think a lot of it has to do with the burdens that they practice under, including burdens from their hospital system, their integrated system. They have lots of requirements from health insurance, both public and private, differing claim systems, differing reporting systems. And I'm wondering if the board and you will consider universal primary care as an option, maybe as the first step, along with other steps that are going to take a lot more time. The first step to dealing with some of our cost issues.
Great question. So, take a poll. How many folks are willing to pay more for health care? You all raise your hand. One guy.
I can't hear, sorry.
Okay. I said there are two folks in this room that raised their hand that they're willing to pay more for health care. So I would tell you, sir, that we have heard from around the state. I've not heard anyone out of 2,000 folks, except for the two folks who just raised their hand, say that they would be willing to pay more for the care that they are getting. I think the question about primary care is a key one, and we do have a lot of things, including the number of things you've identified with paperwork and administrative stuff and fighting with the computer that need to be addressed to help those folks. I think the difficulty is, in part, there is a national shortage of primary care. And having done manpower studies before, it's too low, right? Every manpower study starts with the presumption that the demand is currently met by the supply. And then you project out how many folks are aging out, how many you're going to train, all that stuff. And so you come up with a number now that's 35 to 50,000 people short. It's probably closer to twice that. So part of what we're talking about are some other ways to relieve some of the burden from the primary care. And I think, certainly universal primary care sounds reasonable. It's not been part of our charge. What our charge is to try to help fix what's broken now, and without, a bunch more primary care folk, and people can't get in, I don't see that happening personally.
Yeah, I totally understand. I'm just thinking that type of system, that it makes it attractive for primary care folks to come to Vermont, might be a solution to the problem that you just identified. You can't keep going the same way. We're just going to keep losing primary care folks. You got to change something to make it attractive for them to come and stay.
Fair enough. Thank you.
Thank you. First, thank you for the presentation. When I listened to the presentation, I was a little bit confused. I applaud seeing primary care as being, a real driver to reduce costs and treat people where they are. What I'm concerned about is in the state of Vermont, many, maybe 40% of folks are underinsured, which then they're doing bonds. right? So they still need to show up at the hospital. They'll still need to show up at the emergency room, or if they don't have insurance at all. So I think that still will be a pressure on our system that will keep our costs up there. And so until we can really solve the access to primary care, and, whether it be universal primary care, to me, I think, saying that it automatically is going to increase our costs, I'm not sure that's true. I'm chair of the school board, and the public, the community here, for this next year, is going to be paying $5 million of our budget, which is healthcare premiums. And that's up substantial, right? And if in fact we increase 20%, like you hear it's even maybe higher, that's another $1 million, right? So if I add up the amount of money that we're already spending on behalf of others in the state, such as through our schools, through our employees, we're already paying. Those are two major employers in the state. So we're already paying a large portion of insurance for others. And if we could, figure out how to solve the affordable access to primary care, I think there's savings there. I kind of took offense to your statement that how many people want to increase their health care, what they pay for health care. That may not necessarily be true. We're already paying a lot in the state based on the high percentage of people other than ourselves that we're paying for insurance.
Right, no, you're right, and that's my point. Right, when you've got a state budget of $6.4 billion, then rearranging the way things are done within that gives the opportunity to address the points you're making. Right, I mean, I agree, we have the same issue in Massachusetts. Right, property tax, the whole thing. So, no, you're quite right. And I think that, to me, is a major opportunity for you, because you're right, there are a lot of people who are underinsured. There are people who are insured but still can't afford the out-of-pockets. They still wind up in the emergency. So those things have to be addressed at a community primary care, mental health level. And that's where some of that funding needs to be redirected. Okay, so I'm with you on that. I apologize if the question was offensive. Didn't mean it to be. But, I agree with your point. And I think that's part of the challenge. Now, we do, like I said, there are a lot of recommendations. We're discussing primary care is another 2 hours, right, or more. So, and so is need for nursing homes and home health and a lot of other things. We're at 8 o'clock. Can we take 2 more questions? And then I would just remind people that the Green Mountain Care Board has a website. These slides will be on that. I would encourage you, if you think about something when you leave or tomorrow morning, or you didn't get to say something, please go on that and make a comment. And we do monitor those, and from time to time somebody says something, well, I've got some information here, and we call it. So would appreciate your doing that. Yes, sir.
So my question is very brief, and it's for the audience, and anybody who has the answer can come up to me afterwards. We're talking about a healthcare crisis that involves cost containment. And for me, I think the long-term solution is health improvement, which oftentimes has little to do with healthcare. So I understand that we have a short runway to address the financial aspect of this, but where are the conversations in Madison County about overall health improvement?
I'm Angela Lynn, and I run a local newspaper, and this is a question about what to own, actually. These are very complicated issues. We have a great
full house tonight, 3 people here, 36,000 people in the county. How do you get this message to them? What is the board looking at? What process are you looking at to get this message out and to build the momentum that you need to change this environment? So any ideas? I'd love to help, but John Flowers is here writing the story. It's very difficult to get this out there. I guarantee you.
I don't have a mic, so I'll try and speak. Nice to see you, Angela. And I read a piece in journalism this last week in 7 days. I really appreciate it. And I think part of it is having media coverage, right? I mean, the other is, I actually was remiss not to thank the Care Board staff for the work they've done to put this together. Getting 100 people out on, I don't know what date it is anymore, but whatever day it is really impressive in a small town at night with people working really hard. A number of providers are here, people from our healthcare system. So the Care Board's gone to immense, Daniel and Hillary, and Susan, immense effort to make sure the message gets out to get the attendance. And then second, we're doing as much media as we possibly can to flag these issues. They're also being brought up every week in our public Care Board meetings, how critical we think this issue is. So we're trying to be as open and transparent and available as possible to raise these issues. So if anybody wants to talk about them or bring them up, we're here, we're available, we'll make time to do it. And we're meeting with legislators and others, AHS, in partnerships where we're all on the same page and all the same sheet of music and understanding issues.
I'm just curious, I wonder in your other meetings around the state, are groups like this one, as this gentleman just said, are we forming committees, are we forming groups to keep this going and to push this along, or is that being done anywhere, or I'm just curious?
Yeah, good question. Some communities have been raising ideas of how the community can stay involved and stay connected on their own. Brattleboro had this idea of they should have their own, I forget, monthly, bi-weekly meetings to hold themselves accountable and their community to make the change. But the plans on what we will all be doing from the state side are in development, and we're working on them now. So AHS convened a meeting already to start meeting with hospital executives and leaders. Dr. Hammer's report will come out, that will be public. And I think once we get the report and see the menu of options, this is yours. So you're welcome. Then I think a lot of the more conversations will get underway.
Thank you.
Any other questions?
Thank you all. One more and then we'll call it a new.
Is everybody who's gone once done? I don't want to have you. Okay, real quick. Howard, I know you have been with Geisinger Health, and that's a large vertically integrated healthcare system that actually Kaiser is to go over. And, you know, in my opinion, like a large vertically integrated monopoly that does not have uniformly good reviews, by the way, might not necessarily be the model for Vermont. So I just want to ask, is that being put forward by you and the Vermont Care Board as a model or not? I just want us to be assured of that.
Yeah, no. No, the short answer is no, that's not the model for you guys. All right. You know, I would respectfully point out that I took care of about 2 million people with this surface area larger than the state of Vermont. But it's not the model for you guys. Okay, so we're not talking about that, and we're not talking about Kaiser. Thank you for the question. Okay, listen, thank you all very much. You've been very attentive. I'm amazed everybody stayed awake for my talk. And appreciate your comments and thought. We will certainly add them to our stew of things to think about and work through. Wish you all a good evening and good rest of the